Okay, hi, my name is Diana Hanson. I'm a pediatric audiologist at Iowa Ear Center. Next to me is Emily Getz. She's our student extern this year, and she's going to be helping out in this presentation. We're talking about hearing loss today and how babies are identified with hearing loss. When a baby is born in the hospital, all babies have to have a newborn hearing screening before they leave the hospital. And most parents wonder, how can we do that with my baby who just sleeps all the time and can't show a response? But we use equipment that allows us to measure sound coming out of the ear when we put a sound in the ear. And it's a very painless test that we use. It's very fast, non-invasive, and it can give us an idea that the ear structures are working normally. That's one test, and that's called otoacoustic emissions. Some hospitals have two tests that they use. They all use otoacoustic emissions, that screening test, and if babies don't pass that, they might do what's called an automated auditory brainstem response, which is a little bit different in that we put electrodes on the baby's head, and I'll demonstrate that in a little bit. With those electrodes and little headphones over their ear, we're able to measure the brain's response to sound. With that, we're testing at one soft level when we're doing a screening. If babies pass that, it is assumed that their hearing is adequate for speech and language development. If your baby didn't pass one or both of those tests, it would be recommended that they come in for a follow-up screening within 2 weeks. And most places that see babies that do testing are able to get your children in that quickly. If there is hearing loss, we want to identify it as quickly as possible so that intervention can occur quickly, and that's very important for speech and language development. So, if your baby didn't pass the screening, they would come in to a clinic and have the otoacoustic emission test done. And I'm going to demonstrate that on Emily so you can see how quick and easy and painless it is. What I'm going to do is just put a little probe or a tip in the ear canal. And what I'm going to do is present sound at mid to high frequencies. Okay, so that didn't hurt Emily at all. I want to show you what it looks like. So what we have on this screen here, the blue X's are her left ear's response to 6 different pitches that we tested in her ear. If the blue X's are above what we call the noise floor, which is this response at the bottom, and above meaning significantly above, we would assume that the inner ear, the cochlea, is hearing those sounds that we presented and sending a sound back out. And Emily's going to do the same thing on me because I have a little tiny hearing loss, and so mine are different. Okay. So you can see mine are absent. So the noise went in, I did hear it, but I don't have enough what we call response in my cochlea to have that emission come back out. So now the red circles, which is for the right ear, are above, just directly above the noise floor instead of way up at the top of the page. So that indicates that there is potentially hearing loss or earwax stuck in the ear that's not allowing that sound to go in, or fluid behind the eardrum which can cause babies not to pass. But in my case, I do know I have a little bit of a hearing loss, so that's why that result came up. So this is still technically a screening, but if babies pass this test, and this is the test they had in the hospital, they certainly are suspected to have normal hearing. Okay, if babies had that ABR screening in the hospital, they need to have another ABR screening at the follow-up visit. I don't have that screening equipment. I have a diagnostic test that we use to show that to parents. So I'm going to hook Emily up to that type of testing so you can see what that looks like. It would be very similar in our office compared to all the other offices that can do the screening. So what we do is we just use a little bit of gel here to clean a few spots on the head. So forehead, usually the cheek, and then behind each ear. And for today's purpose, I'm just gonna not do the other ear. Since it'd be hard to get over there. And then I just kind of wipe that off like that. Then, just gonna grab, these are called electrodes, and it's very important when we're doing any follow-up testing on your baby that the baby be content and sleeping. The more noise there is, the more difficult it is to get the results that we need. If a baby is noisy, it becomes difficult for us to know if the response we're looking at is actually their hearing response or if it's a noise-induced response. So one thing I would say is that if you are bringing your baby in to have follow-up testing, make sure they have a clean diaper, that maybe you've sleep deprived them a little bit so that when they're here, they're ready to go to sleep, maybe after you feed them. If you've had a long drive to get to the clinic, that makes it more difficult. The more you can prepare your baby for this testing, the better. But the baby needs to be asleep in order for us to know for sure. So, and we allow 2 hours for this testing because we know that that baby might not be ready to go to sleep right away. The test itself, though, only takes about 30 to 45 minutes if all conditions are good in order to know if that baby is responding. So the difference with this, if we're doing a screening, it would look very similar to this. We would still just test at one soft level. If that baby doesn't pass that and they need this diagnostic auditory brainstem response, then we connect these electrodes again, use a little insert headphone, and we're measuring not just at one pitch at a soft level, we're measuring at multiple pitches from loud to soft. So we can make it as loud as we need to in order to try to see a response, and then go down to the very softest levels to see if that baby hears. And that's at the low, the middle, and the high-pitched sounds, not just a high-pitched sound, it's the whole range of hearing, and we would obviously test both ears. One other thing I can say is that hearing loss is the most prevalent disorder that is identified at birth. So usually between 1 and 4 babies of 1,000 babies that are born have some level of hearing loss. So that's why newborn hearing screening exists, and these follow-up tests happen so that we can identify these hearing losses at a very early age. I mentioned that before. So we have Emily all hooked up. We would simply turn the sound on. We would hope she would be asleep and close her eyes and relaxed for the testing. That way we're going to get what we need to see. So this is what it looks like if the response is normal. At a loud level, we see peaks, 3 big peaks essentially, that show that the auditory nerve or the inner ear is responding to sounds, or the brain is responding to sounds that we're putting into the ear. So loud means the peaks are going to be bigger. The softer we go, this is kind of a middle level sound, we see less of these first two peaks, but we're still seeing this third peak, but a little smaller. And then when we get to the very softest level we test, we still see a very small peak, that's called wave 5, present, and showing that that child is hearing at what we call 20 decibels, which is very soft and really considered to be normal hearing. So that shows a good response. Okay, so this is what it looks like if a child has hearing loss or a patient has hearing loss. We're testing still at very loud levels. We see essentially a flat response. There's no peak that repeats itself. So we know at this point that the brain is not responding to the sound that we're presenting. So that is suggestive of hearing loss. So with this testing, we can test at loud levels down to soft, and when that waveform goes away, that's when we assume that that is the threshold or the softest sound that child can hear at that particular pitch. And each pitch that we're testing looks a little bit different, and that's not as important as whether the peak is there or the peak is absent for parents' perspective. So now, if your baby didn't pass a hearing screening and they had the diagnostic testing, there would be additional things that we would do to confirm whether there's hearing loss and what type of hearing loss that might be. We would do that otoacoustic emission test, which I showed you at the beginning, which is the probe in the ear and confirms whether there's hearing loss or not. So another test we'll do is called tympanometry. It measures whether there's fluid or earwax or something in the ear. It bounces a sound off the eardrum. I'm going to demonstrate that on Emily so that we can see what that looks like. Emily, I'm going to have you hold that. Sure. So what I got with her is a little peak on the graph that shows when sound went in the ear, the eardrum is supposed to vibrate, and that's what I'm measuring here. If I got a flat line, that would indicate that the eardrum was stiff, sound wasn't able to get down into the inner ear. So in that case, we would suspect that at least part of the hearing loss was due to fluid or something that could be a little temporary. If we have a normal tympanogram and ABR test that is showing hearing loss, in those cases we would recommend hearing aids for those kids. And so the national goal with hearing loss is to identify or screen a baby by 1 month of age, confirm whether there's hearing loss by 3 months of age, and fit hearing aids and start intervention, speech and language intervention, by 6 months of age. These goals have recently changed. Instead of 1, 3, 6, now we're trying to do 1, 2, 3. So have the screening by 1 month, have the follow-up and identification by 2 months, and fit the hearing aids and start the early intervention program by 3 months of age. And I think that's wise, because if there is hearing loss, the sooner you can have those babies start to wear hearing aids, the better. Studies have shown that if babies are appropriately fit with hearing aids by 6 months of age, again the old guidelines, that those babies do well and are school ready for kindergarten by the time they are 5 or 6 years old. So it's important to know that while 6 months is still a good guideline, the earlier the better. Some causes of hearing loss can be family history of hearing loss. Maybe you have other family members that were born deaf or developed hearing loss at later ages. Sometimes hearing loss can progress. It can start more mild and get a little bit worse. There are virus or infections that can cause hearing loss. CMV or cytomegalovirus is one that is starting to be more well known, and that is a big incidence of hearing loss children that have CMV. Other factors can be if your child has Down syndrome or some other syndrome, hearing loss can be associated with that. Ototoxic medication, if the baby was in the NICU, the newborn intensive care unit, they may have received some medication that could cause some hearing loss later on. And those babies are often screened and followed up, sometimes several years later, just to make sure that we still are not seeing any hearing loss. So that concludes my presentation. If you have any questions, you can sure find my name on the EDI website. Happy to answer any questions you might have.